The U-World Global Lecture Series presents 4 lectures and panel discussions on the topic of global health, featuring faculty from disciplines across the University of Washington campus. This series, A Just Cause, Bringing Healthcare to All, is presented by the University of Washington Office of Global Affairs, in partnership with the UW Alumni Association. Video production was made possible through generous funding from the University of Washington Department of Global Health, with additional funding from College of Arts and Sciences, Marc Lindenberg Center for Humanitarian Action, International Development, and Global Citizenship, and the University of Washington. In this lecture, The Promise of Health for All, speakers explore the complex forces which impact our ability to provide basic health care to citizens in a global society.
I'm excited this evening to introduce our moderator, the Honorable Daniel J. Evans. He is, of course, best known for being our 3-term governor in the state of Washington and for having been recognized as one of the 10 outstanding governors of the 20th century. We are honored that the School of Public Affairs here is named after him and that the school carries on the great traditions and values and leadership that he established as governor. In 1983, he was appointed to fill a vacancy in the U.S. Senate after the death of Henry M. Jackson, and he was then elected to complete the term. This year marks the 50th anniversary of Dan Evans' legacy of public service that began then in 1983. His reputation is one of collaboration, as he is well known for his ability to work with others to find common goals and interests. He has dedicated his life to public service, and he continues to contribute to the betterment of our state and our society. Governor Evans and his wife Nancy have tirelessly committed themselves to helping others, from individuals to institutions, and their mark will be indelible as we go forward. So I hope you will join me in welcoming him this evening as our moderator, Governor Evans.
Thank you, Susan. It's far too generous an introduction. I have identified myself in recent meetings when they go around the room and ask what you're doing and what you're engaged with, and I call myself a community pest, which is not a bad thing to be. And I have a long relationship with the University of Washington. I not only started my schooling here 60-some years ago, but far earlier than that, along with youngsters in the Laurelhurst neighborhood, snuck into football games by climbing over the fence and running from the few guards that they had there. We were much faster than they. Tonight we're going to hear about health systems. We've made a lot of gains as a nation in providing technology, medicine, on-the-ground care, but we still struggle with providing basic health care to most of the people of our planet. So despite these great strides in some areas, we still accept the number of deaths of children worldwide without really dramatic intervention. And we can't look at the person next to us or political leadership to guide us. In a situation like this, we all need to lead. In a speech I gave in 1969 entitled The Linfield Priorities, I said, "It is about time that the citizens of this country began to take stock of themselves." In that context, I was talking about fighting ignorance and war and poverty within our own borders. But our world has changed dramatically in the almost 40 years since that speech. So I think the statement still holds true. The context has changed. It is time for us to take stock of ourselves and make a greater commitment to changing this grim situation for citizens around the world. We need to look across our borders to the welfare of global neighbors as well as the citizens of our own country and commit to adequate care. Our democracy still does grant us power that we must embrace. The processes are in place to change policy and affect outcomes for people around the world. Now let me introduce the speakers for this evening. They will each give a presentation, which will then be followed by a question and answer period, so think about what you want to learn more about. Steve Gloyd is the director of the International Health Program and also a professor in health service and family medicine. He's the executive director of Health Alliance International, a Seattle-based nonprofit which provides support to the ministries of health in Mozambique and East Timor. He has more than 25 years of experience in working in Africa and Latin America. Steve Gloyd thought that he wanted to be a doctor just like his father, but as he grew up, he started to lean toward rock and roll as a career. But Vietnam kept him committed to pursuing his education and pushed him into medicine. Boy, how much that war created guidance for people and their careers. After finishing his residency, he worked as a community activist and free clinic physician here in Seattle, after which he signed a long contract with the Ministry of Health to help build Mozambique's model primary health care system. He went on to be a frontline doctor and district medical officer in Mozambique, which he considers his second home. Sanjeev Khagram is the faculty director of the Marc Lindenberg Center for Humanitarian Action, International Development, and Global Citizenship. He's also an associate professor of the Evans School of Public Affairs and in the Jackson School of International Studies. Prior to coming to the University of Washington, he held positions at Stanford and Harvard and was most recently acting dean of the Desmond Tutu Peace Center. He is active across many organizations, has published extensively, and continues to work with governments and agencies worldwide. Sanjeev was prompted into the field of humanitarian efforts because of his own personal history. Born in Uganda during the regime of Idi Amin, his family was forced into camps as penniless refugees after being expelled in 1972. We honor his contribution to this field. You can read more about these speakers on the website for this series, which is www.uwalum.com. And so now we will welcome Dr. Steve Gloyd to the podium. Steve, come on up. Thank you.
Thank you very much, Governor Evans. That's a very nice introduction, and go Rough Riders. What I want to talk about is the issue of U.S. policies and U.S. policies affecting global health. And I wanted to start by saying that when I started this odyssey in global health, in 1979, I was a clinical doctor for the Ministry of Health in Mozambique, the only doctor in a rural district of about 150,000 people. And most of the people that I saw were kids, adults, maybe 20 to 40 per day, who were seen by nurses and referred to me. They had pneumonia, they had dehydration, they had malaria, they had meningitis, almost anything you can imagine. And most of the kids had been seen in the preceding month or two or three. We treated them, they went back home to the conditions that got them sick in the first place, with inadequate water, sanitation, housing. And usually within a month or two, they would come back again. At the same time, I remember that we were interested in malaria. We had a lot of malaria and wanted to see how prevalent the malaria was. So we did a survey among the workers at the nearby sugar plant. And we tested about, I think, 150 at the time, young men who were quite well, looked well, to see if they had any malaria in their bloodstream. And it turned out that about a quarter of them were infected with malaria. A short time later, we did a school survey among kids in 20 schools in the region where we worked. And virtually 95% of those kids were infected with schistosomiasis. The point I'm making is that when you're dealing in many poor parts of the world, it's not a matter of addressing one disease or even two diseases. What we're talking about are the conditions which create one of a multitude of diseases that we can treat, but if we treat them, the kids or the adults will simply come back with another disease. Since then, little has changed for the better. Health clinics have gotten worse. AIDS has devastated the region. TB and malaria are still rampant and now resistant to drugs. The rich have gotten richer, but the poor are still poor, and by comparison, even more poor. Most families can't afford a $3 bed net in Mozambique, where I worked 25 years ago. And the bottom line is poverty and disparity. And there's a sense among us who live in the United States that poverty and disease are somehow natural, the natural conditions of Africa. And we talk about what the conditions are, what we can do. NPR had a series last week. I hope some of you listened to it. It was actually quite good. It was about Africa's lagging development. Why are they poor? It focused on food production, on disease, appalling governments, and trade, but almost nothing on U.S. policy. And yet poverty and disease are, in fact, and I hope to show you this, are created by conditions over which we have a remarkable amount of control. And it is us, our government, which can make a huge difference in the poverty and disparities that exist in the world, as long as we know what our government is doing. And I think for the most part, we tend not to. So what I'd like to do today is to talk about poverty and health, the past progress in improving health, and the positive role of governments, because although we have a gloomy picture right now, we actually have pretty substantial possibilities of improving things. And then talk about 3 levels of policy that impede our progress. One are structural adjustment programs. The second is foreign aid and our particular form of foreign aid. And the third is militarism and violence. And then finally, we'll end with alternatives, hope, and what we can do. And Sanjeev will be able to follow that with some of the ideas of the kinds of things we can do with more specificity. First, deaths and illness. In 2005, 11 million children died from preventable causes. In 10 African countries, over 20% of children didn't reach the age of 5, and in 16 countries, more children are dying now than 15 years ago. That's really concerning. Over 500,000 women died in childbirth in 2005, and that's been about the same for the last 20 years. We haven't made any progress at all. And about 3 million adults died from AIDS and 2 million from tuberculosis. So the toll is astounding. If you look at the under 5 mortality, you see the patterns that we see over and over again. The dark red is over 10% of kids who are born alive don't reach the age of 5. This is, of course, not counting the kids who die in stillbirths, which are very many. And in fact, in the subcontinent of Africa, where you see most of the disease, as well as a few other places in the world, that about half of those countries have nearly 20% of the kids who don't reach the age of 5. Why do the kids die? Well, we know from study after study after study for many years that there are about half a dozen different issues that cause most of the conditions which create illness and death. And those are education, particularly education of women, nutrition, family income, water, sanitation and housing, health care, war and violence, and inequality. The common denominator, as I said, is poverty and disparity. If you look at the first of those issues, education is probably the biggest. It's bigger than issues of income and nutrition combined. Primary education completion rate, if you look at that, you get the same pattern that you saw in the mortality pattern, that most of the poorly educated people are in sub-Saharan Africa. The dark red is less than 50% who completed primary education, so that most of sub-Saharan Africa is in that group. If you look at the leading causes of death in children under 5, there are all the causes that I talked about that I faced back in 1979. Pneumonia, malaria, measles, diarrhea. HIV/AIDS is new among kids, and it's growing. But the important issue is that malnutrition is the underlying factor in 60% of all those deaths, so that if you don't die of pneumonia in one time, you'll come back with malaria another time or come back with diarrhea another time. So we can't just address diseases. If you look at family assets, it's very clear. The yellow is the poorest families, and the blue is the richest families. And if you look here, you can see that in Haiti, India, Indonesia, and in Togo, where you're poor, your mortality is sometimes half again as low, or, excuse me, as high, or 2 or 3 times as high as those places where the population is richer. So it does make a difference. Also, medicine makes a difference, particularly in the era of antiretroviral diseases. If you have 3 million people alone who are dying of HIV-related diseases, another 2 million from tuberculosis, we now have relatively inexpensive medicines that can, in fact, transform the nature of the epidemic, but we're unable to get those out, and much of that comes from our policies. So looking at the big picture is what causes ill health in the world? And this is a slide that I think many of you may have seen if you've heard me talk before, because this is my kind of global view, which is that we start out here with disease. We start out here with diseases, and these are the ones that I talked about that are pretty common. They're, in fact, except for HIV/AIDS, the same diseases that cause the same kind of mortality in the United States, in the UK, and Europe in a century before, in the 1850s to 1900. These diseases are individual diseases, and what happens is that we as physicians, we as health workers, we treat them and they go back into these conditions, which are family, environmental conditions with water, malnutrition, water, sanitation, housing, health services, and health behavior problems, which essentially will push people right back into this disease pattern. But you can't address these diseases without addressing the intermediate nation and community factors, which are poverty, disparity, access to education, job conditions, gender issues, civil strife, etc. But there's nothing natural about these conditions, and that we really have to deal with issues around the interests of the rich, the status of women, land tenure, debt, structural adjustment programs, governments, militarism, and imperialism. And Sanjeev and I will talk about all of these issues in the next hour. We do have some awfully good examples of success stories. Unfortunately, most of these occurred between about 1950 and 1980. The examples that I can give you are Kerala, Sri Lanka. Kerala is a state in India which is bigger than most, or population-wise, bigger than most countries in Africa. Sri Lanka, Taiwan, South Korea, China, and Cuba all pursued strategies that I would call equity strategies. Policies that essentially, that governments put out, offered to their populations as a means of reducing some of the disparities in the population. They were primary education. All countries had that as universal and compulsory. Housing, water, sanitation for the poor, subsidized or public works projects that built these. Food, agricultural subsidies. All of these countries had that. Land reform, protection of nascent industries, only Taiwan and South Korea, because they were the 2 examples of growth-oriented or export-oriented growth that had remarkable mortality declines, and all had simple health services. These regions of the world, and there are a few others, but these regions of the world went from mortality rates where 25 to 30% of the children didn't reach the age of 5 to situations where it was between 3 and 4%. Enormous, enormous decreases in mortality in a generation. And that can be done simply with these kinds of strategies as long as there's a political will to implement them. And the common denominator is that it all requires some kind of public sector intervention and taxation to get the resources to do that. So that was the first promise of Health for All. Health for All in the year 2000 was what WHO and UNICEF suggested as a result of these experiences could be achieved. And primary health care in 1978 was the mechanism to get there. Committed by 134 countries, including the United States, World Health Organization, and UNICEF. But what happened? One thing that happened is what we call neoliberalism. Neoliberalism is a philosophy that de-emphasizes or rejects positive government intervention in the economy, focusing instead in achieving progress and even social justice by encouraging free market methods and fewer restrictions on business. It's also called by George Soros market fundamentalism. We called it Reaganomics back in the era of the Reagan administration. But it's mostly called neoliberalism in developing countries. When Ronald Reagan was inaugurated in 1981, his inaugural speech, he said, "Government is not the solution to our problems, government is the problem." So obviously you have a fairly different theoretical approach to these kinds of interventions. Then what happened was the debt. And one of the questions was exactly how did the debt occur? And I want to give you a little bit of a sense of that, but What occurred in the mid-'70s to the early '80s is that most countries in the world had some form of debt, largely because of a lot of money coming into banks because of OPEC and the price of oil going way up during those years. And as a result, aggressive loans were pushed on many third world countries. And the place that took the biggest hit was sub-Saharan Africa, not because of the overall debt, because the biggest debtor, as I think most of you know, is the United States. And Europe is a big debtor. And Latin America and Indonesia are big debtors, in Asia are big debtors, but sub-Saharan Africa, the debt compared to the GNP is off the charts, as you can see. So what happened during these years is what are called structural adjustment programs. These are programs, also called Saps, that were imposed by the International Monetary Fund and the World Bank, and were called the Washington Consensus because the Department of the Treasury was very much involved with these. And these, were imposed at the time of the Reagan administration, but have been fairly consistently used through Republican and Democratic administrations. So it's not really an issue of politics or party affiliation as it is a philosophy. What essentially happened was that they designed austerity measures designed to reschedule unsustainable debt, slash government spending, particularly in education and health, because that's where you can slash, privatize the economy for water, oil, even health and education, and improve terms for foreign investment, reducing corporate taxes and capital restrictions, and to continue paying the debt, but rescheduled. The programs had the following impact. In terms of slashing government spending, what it meant was mass layoffs of government workers, mostly health and education, because those are the most workers around. Salaries were eroded so that in the situation in Mozambique where I was working, that as a health worker, a nurse who might have been earning $200 per month in 1979, 1982, by 1986 and 1987, the real value of that salary was $30 a month or $35 a month. What it meant is that they were earning poverty wages after having put in 20, 25 years of service. They curtailed maintenance and support of clinics and schools. They ended subsidies for the poor, for food, transport, water, housing. They did exactly the opposite kinds of things that we talked about happening in these countries with the equity strategies. The programs also privatized economies, market regulation of prices, huge increases, elimination of protection for small businesses, willingness to pay for social services, which was a justification for charging fees for not only health care, but for education, which had enormous impact on the educational possibilities of young kids. My wife will tell you that the situation for her back going to school in the 60s and 70s in Ivory Coast, that she had much more opportunity to get an education than a young girl of the same age today. And that's really sad when you think of that happening over 20 years. Improved terms for foreign investment are part of the package, reducing taxation, government income, devaluing currency, and reducing wages and curtailing labor unions. This basically is a strategy designed to shrink governments and provide a better terrain for private investment, particularly the corporate sector. The impact was really clear. If you look at schooling enrollment by itself, you'll see that in sub-Saharan Africa, in all of the world, school enrollment was going up from the 60s to the 80s, and then in sub-Saharan Africa, when these occurred, the schooling started dropping. And the flow of annual debt payments since 1986 has been about $15 billion a year from Africa alone. $15 billion. You think about the money that we give in aid and the Bush administration's AIDS program where we have $15 billion in 5 years, and that's considered a lot, and this is every year. Right now, we've had a debt reduction program in 2005 because of the G8, and that number has been reduced to $14 billion. How have the Saps weakened the national health systems? Well, we've talked about maintenance. You work in health facilities, and this is what happens when I go there now, that where the walls are crumbling, where there's no paint, where the roofs leak. And it's just not a very good environment for health workers to work, much less the equipment that's not working anymore because they don't have any maintenance costs or parts. Inadequate medicines and supplies, limited transport, communication, user fees, which fall heaviest in the poor, and an inadequate workforce and decreased morale, which is probably the most important issue. If you look at the global distribution of health workers in selected countries, you have a situation whereby The United States and Cuba are the countries that are doing reasonably well with about 500 to 600 doctors. The United States is about in the 200 or 300 range, doctors per 100,000 population, with maybe 700 nurses in Cuba. Brazil does reasonably well for a developing country. But look what we have here: Malawi, Tanzania, Mozambique, Ethiopia. We've got 2 doctors, 3 doctors per 100,000 people. And most of those are in urban centers, because the government doesn't have enough money to pay incentives for people to go out into rural areas. Much of this has been caused by policies where, in the case of Mozambique, there was a nurses' strike in the early 90s, and the IMF, basically, the government said, yes, we can settle the strike. I think their salaries were approximately $28 or $29 per month, and the nurses wanted salary increases to about 33 or 34. The strike was long. The International Monetary Fund said, okay, we will agree to pay that increase. The government can pay the increase, but with the stipulation that you can't increase the nursing workforce for 5 years. And this is what happens. So what happens with these systems? Well, this is a graph of immunization coverage from 1980 through 2001. So you can see immunization coverage going up. This is DPT-3, going up, up and up and up. This is sub-Saharan Africa and South Asia. And then when these countries get in their structural adjustment programs, it just levels off. And here where we are, we're at about 50% immunization, and it's stayed that way since the mid-80s. So we've had debt relief, as I've said. There's been a positive, it's been, to a large extent, an effect of global activism, which makes me very, very happy, because there's been a number of groups out there pushing for debt relief. The G8 agreed to cancel 100% of the World Bank and IMF debt for 18 poor countries, which is about $57 billion. Well, that's taken the debt in Africa from about $260 billion to a little over $200 billion. So that's why the debt repayments are approximately the same. And there's no change to the structural adjustment programs. Paul Wolfowitz, the architect of our war in Iraq, is now the president of the World Bank. And what he said is that he's supportive of these debt reductions as long as the countries follow the economic policies that had been imposed upon them before. So you have continued weak governments. Now let's move to aid. Because, you can say, okay, we've got this one side, you've got debt, but American aid should be able to redress some of these problems. Well, first of all, the USA is the stingiest rich country in the world by GNP per capita per aid. Politics dictate our decision about who gets aid. So the biggest recipients of aid are Israel, Egypt, Pakistan, etc., depending on who's in fashion, although Israel and Egypt are always in fashion. At least they have been for the last 20 years. Most aid money eventually goes to Americans, and I'll show you why, and it often exacerbates some of the very problems that have been created by these structural adjustment programs. First of all, here's our development assistance as percentage of the gross national income, and you can see that we're down here quite stingy. We're very, very much under the UN target of 0.7%. That's not even 1% of our gross national product, whereas the Scandinavian countries are well above it. If you look at the generosity and to whom, here's the numerical value. We give $46 per person per year in this country, as opposed to Norway's $373. And yet, we also only give about a third of our money to the least developed and low-income countries. Most of it goes to better-off countries. A lot of that's because of Egypt and Israel. Then let's look at our objectives. Why should this surprise us when you look at the objectives? Well, the objectives of USAID, and this comes from a 1990s, I think it was 93 or 94 document, but it stayed the same from about the mid-80s until now. And the objectives of U.S. foreign assistance are to expand markets, promote security, promote U.S. values, and humanitarian. And in fact, in the 90s, they were listed in this order. Well, what does that mean? Expanding markets means tying aid to purchase of U.S. goods and services. It means making sure that you use branded drugs, which is what we do in our HIV programs. So the value of the aid is much less than it otherwise would be. Promoting U.S. security usually means helping our favorite countries. Promoting U.S. values. Well, what are the values that we promote? Well, if you look at aid and what we do worldwide, it's a hard case to make that we support democracy as such, but the value that we for sure support is economic freedom, if you will, or free trade, which is essentially corporate trade, and then humanitarian. Here's the way the aid money goes. You've got funding that comes from USAID, and the size of the arrows are about the size of the amount of money. It goes to non-governmental organizations, and non-governmental organizations like Save the Children, World Vision, CARE. These are organizations with annual budgets of about $300 to $600 million per year. So they're fairly big, and it's basically an industry. And by the way, I'm, as Governor Evans said, I'm in an NGO myself, so I have to do a buyer beware here on this. The non-government organizations, they have their indirect costs. Some of them are up to 100% indirect costs. A lot of them are between the 15 to 30%. High staff salaries, because it's very hard to hire people with lower staff salaries. Columbia University in Mozambique is paying their physicians in Mozambique $170,000 per person to work, when their doctors who have the same training, who are Mozambicans, are earning in the neighborhood of $10,000. Staff support, cars, housing, offices, et cetera. You're not going to pay people high salaries unless you give them cars and nice houses, et cetera. And it makes sense. And then some of the money goes to local NGOs, direct service delivery. Very little of it goes to ministries of health, which are the places that are lacking money. We estimate, ActionAid estimates in the 60%, I estimate in approximately 80%, and that's because of PEPFAR, the AIDS treatment, that about 60 to 80% of the aid is phantom aid that essentially goes back to U.S. hands rather than getting to the recipients. And then there's the management burden, the donor-induced management burden. In the case of Mozambique, where you have over 200 health NGOs who are all in that same pattern, 150 independent sites of operation, 10 to 20 program categories, independent planning cycles, implementation, and the reliability dependent on the policies. This is a graph that shows 1371 different projects with 18 donors in Tanzania. Each one of these little bars is a different project. Each one of it has a different funding cycle, a different mechanism of reporting. Imagine the management burden for these ministries of health who have lost all their workers because of structural adjustment programs. And then you have the final hit, which is the non-governmental organizations. Because they're paying higher salaries and benefits, they also take the health workers, they draw the health workers in an internal brain drain to the non-government organizations to work. And this happens to us all the time in Mozambique, where everybody who's in the ministry, the best people in the ministry, want to leave because they can earn 5, 10 to 20 times as much. Finally, I want to end on wars and militarism. And Sanjeev, I think, will continue this discussion. There have been 250 wars in the 20th century. You can see some of the data here. I think Sanjeev will go over it more. You've got landmines, refugees, torture, rape, mutilation, and destruction. The U.S. arms industry is larger than the rest of the world combined. Every year we sell over $6 billion of arms to poor countries, and it's a very lucrative industry which is subsidized by our government. The UK subsidizes there. These are all subsidized industries. I suggest you see Lord of War. It's a great movie. The problem is it's true. And if you look at U.S. militarism, we have 700 bases, $500 million or billion-dollar budget defending our vital American interests, which are what? Well, it's security, values, markets, and humanitarianism. It's probably the same kind of thing that we just talked about before. And I like to show this, it's a little hard to read, but these are the 30 interventions that have occurred just since World War II. And it gives you an idea that we purport ourselves to have the high moral ground, and that what's happening in Iraq right now, or what's happening in Afghanistan, or what's happening in these other countries is an aberration of what is otherwise a benevolent country. And I would suggest is if you look here, and as Governor Evans said that my own background came from the Vietnam War, you look and there's a remarkable consistency of what we've done, to a large extent to protect our vital national interests, which to a large extent is corporate trade. General Smedley Butler said in 1933, war is just a racket. Only a small inside group knows what it's about, conducted for the benefit of the few at the expense of the masses. He spent 33 years in the Marine Corps, he said, as a high-class muscle man for big business, a gangster for capitalism. I helped make Mexico safe for American oil interests in 1914. I helped make Haiti and Cuba a decent place for the National City Bank boys. I helped the raping of a half a dozen Central American republics for the benefits of Wall Street, and I bought life to the Dominican Republic for American sugar interests in 1916. In China, I helped to see it that Standard Oil went its way unmolested. Looking back, I feel I could have given Al Capone a few hints. This is 1933. Let me suggest that the problem is how can we promote equality while still retaining our advantage. And then finally, I want to leave you with an optimistic note before I give the podium to Sanjeev. There is an increasing understanding of debt and Saps. We've got Bono. We've got Bob Geldof. We've got Brad and Angelina. We have Oprah. There's been a repudiation of neoliberalism in Latin America, so that in Brazil, Bolivia, Chile, Peru, Venezuela, Uruguay, and now Ecuador, a couple days ago, are voting in presidents of those countries whose political platform is anti-neoliberalism, anti-US. Positive experiences with debt reduction in Kenya and Mozambique. New forms of international aid. There's a swap process. There's the Global Fund that Sanjeev will talk about. The global anti-war movements are the largest in history. And finally, what I see over and over in where I work in Mozambique, Ivory Coast, elsewhere, is that despite the poor salaries and conditions, that there's an incredible professionalism of health workers everywhere. We do have the resources. I don't have a lot of time to go through this, but as you can look at where we spend our money, we're doing pretty well with a lot of issues, and we don't have a lot to spend on health and education. What can we do? Understand and witness the detrimental aspects of our policies, cancel poor country debt, and combat neoliberalism, to help rebuild the public sector overseas. And a lot of organizations are doing that. We can work to change our forms of aid. I'm not saying stop aid. I'm saying we should change our forms of aid, and we can curb US militarism. Thanks very much.
Good evening, everyone. Several times since I've come here to the University of Washington, many people have asked me, you have quite a resume, why the University of Washington? And I said, you know, when I came here, I met some incredible people, many, many incredible people. Sandra Archibald, the dean of the Evans School. Anna Yang, the director of the Jackson School. Susan Jeffert, our now Vice Provost of Global Affairs. I had a wonderful conversation with our president, Marc. And I asked him, what's your vision? What can I do to come and help you achieve? And he says, we want to be a global university that gives back to humankind. And we want to train our students to be global citizens. As Governor Evans mentioned, the issues I'm going to talk to you about in my more academic talk, more scholarly talk, are very much connected to who I am and where I came from. About 30 years ago, my family was expelled from Uganda after being citizens for nearly 4 generations. And Steve will know, many of us who have worked or lived, citizens on the continent know, that at that time, Uganda was the pearl of Africa. Not that it didn't have lots of challenges and lots of problems and internal racism and underdevelopment, effects of imperialism and the Cold War, but it really had what many people thought what it took to be a success story in Africa. And what came about with the dictatorship of Idi Amin and the subsequent 15, 20 years of civil war was a complete destruction of much of that hope and possibilities. Not only were my family and 100,000 families of Asian descent expelled, but many, many, many Black Africans suffered needlessly. Death, disease, lack of access to all the things that Steve mentioned. For us as a family, we were taken to refugee camps. And for me, that of course was a very powerful experience, certainly for my parents, my sister. But the amazing thing about refugee camps is that after you leave them, if you have the great fortune of being supported in taking the next step forward, is you know what great possibilities there are for changing our world. We were invited by the US government as refugees as part of a political asylum program to move to the United States. And for my parents, there was no choice. The United States was the land of freedom, the land of hope, the land of possibilities, the land of education, the land of democracy. I still believe in that United States that welcomed us. And I believe we all believe in that United States. And somewhere along the way, we went awry, as Steve has begun to outline. But I know, with leaders such as Governor Evans and leaders like all of you, from the grassroots to the global, the United States will once again be that positive force for hope and change and global health and education and democracy, true democracy. So with that, let me begin my presentation. What are the conditions of public health? I won't take much time on this. Steve has outlined this. You all are wonderfully educated and committed citizens. We need to meet the basic human needs of people, including sufficient food, clean water, and adequate housing. We have to make healthcare available and public health services available to all. We have to create healthy and safe physical and political environments. And we never can forget that healthy socio-cultural environments are as important as all the other institutional and physical foundations. I want to focus my talk on political instability and public health, not surprisingly. As you see from this slide, political instability can lead to state failure associated with violence, criminality, and the international transmission of disease, poor health, and one can go on and on. The threat of political upheaval and the prospect of a new regime discourage investment, preventing improvements in economic growth and welfare, and so much more. If I could maybe take too strong a move from Steve's talk, in my view, without good governance, and which I'm going to talk about in a second, all of the other things that we are trying to achieve in this world cannot be achieved. And the United States, both as a government and as people, can contribute to good governance, not only around the world, but here at home. Conflict, the direct effects on public health. Injuries or fatalities associated with warfare. 90% of all deaths related to war are among civilians, many of them women and children. The human cost and disability-adjusted life years, it's estimated war on average causes an estimated 500,000 disability-adjusted life years per year, and it's growing. Effect on health infrastructure and capacity. There's a tremendous physical destruction of health infrastructure and the supply chain, and a number of wounded and critical overwhelming of capacity. Many of you seen, perhaps on CNN, perhaps in the newspapers, a recent study from some colleagues at Johns Hopkins, reporting the casualties and public health consequences of the war in Iraq. The pre-invasion mortality rates were 5.5 per 1,000 people per year. The post-invasion in 40 months went up more than double to 13.3. Excess deaths in the post-invasion period were 654,000, more or less. Of course, deaths due to the gunfire and related violence were 600,000 of those 654,000. Deaths due to related illness, another 54,000. As importantly, health conditions due to the violence decreased dramatically, were affected because of an insufficient water supply, non-functional sewage systems, restricted electricity supply, deteriorating health systems and inconsistent access to health services, brain drain of health professionals, displacement, and I'll come back to this, due to sectarian violence. Now, there's been much debate about this study, and many of us believe that it was an incredibly well-conducted study, systematic, with the highest standards of rigor and ethics in research. But even if there was a 10%, 20%, 30% overestimation of those deaths, would we feel any better? I don't think so. There's a tremendous diversion of resources away from health and social service. During conflict, military spending increases on average by 1.8 to 2% of country's GDP. That means cumulative 20% of GDP in 10 years following. There's shrinking state budgets, disproportionately affect lower level care centers, health care, all the things that Steve was mentioning in his talk. There's a tremendous range of indirect effects of conflict and poverty on public health. Conflict and the search for income increases and stability, livelihood, increases population mobility and displacement. One of the effects is an increase in number of sexual partners, activities, sexually transmitted diseases, marginalized population, especially women's exclusion from the public sphere, that is to say government, often blocks access to health services. Conflict and poverty affects the health of women and children over and over again. This is so clear. It increases discrimination, sexual violence, forced rape, mutilation, forced abortion, forced prostitution. It is estimated that 20,000 Bosnian, Serbian, and Croatian displaced women have been raped, and that is actually an underestimate. And it increases already high rampant corruption and levels of political instability. Displaced populations and their common health risk, overcrowded living conditions and unsatisfactory hygiene conditions in refugee camps. The quantity and quality of healthcare is usually even more greatly reduced from already incredibly low levels. Disruption of basic services. Programs, vector control, outreach services are typically more than impeded, rarely even exist. And one that I'd like to highlight in particular, the long-term mental health problems. The displaced mortality rates, 80 times higher than normal baseline rates. In June 2004, the World Health Organization estimated 1 million displaced people in Darfur. The current death rate is an estimated 6,000 to 7,500 per month. Sexual and gender-based violence. It's hard to even talk about, but we know these are the facts, the daily facts of life in these kinds of situations. Children's health. During conflict, 95% of child deaths are caused by starvation or illness. And in 1996, and this actually figure has increased, there was an estimated 2.5 million children separated because of armed conflict, the future of our planet. Nutritional deficiencies. Most refugees from armed conflict have fled to disadvantaged countries that can't afford to care for them, which creates a double whammy because those countries can barely take care of their own populations, and now you have the additional burden of the refugees. Disease associated with conflict exacerbate already low vitamin reserves. One can go on. I think one thing that I want to highlight is the role of corruption. It damages the ability to deliver high-quality, effective care, increases poverty and inequity, which deteriorates health status, diverts public money into private hands without benefiting patients, and exacerbates political instability and contributes to armed violence. Again, here, when it came to international anti-corruption, the United States was a leader. After Watergate, we were the first country in the world to implement an Anti-Corruption Practices Act. It took Europe 20 years to get on board. We now have global anti-corruption conventions, but that's just the beginning. We know that corruption, which is collusion it is collusion between northern and southern partners, and it's not just a problem of corrupt dictators in the South, continues to undermine many of the global goals that we have, including public health. You can see that corruption is highly correlated with health services, and the less corrupt, the more likely you're going to get healthy service that's very good or fairly good, and of course, the more corrupt, the worse the service is, if at all. So good governance matters. What is good governance? The process by which those in authority are selected and replaced. What we care about here is transparency and accountability, and political and societal stability. It's the capacity to formulate and implement policies. It's about government effectiveness and regulatory quality. It's the respect of citizens, by citizens for the institutions that govern them and the interactions among them. In particular, it's about the rule of law and the control of corruption. If you see here, this diagram, inverted, basically, table graphic from the corruption graphic shows that with good, high governance, the development dividend is tremendous. High governance, and you see, leads to average incomes around close to 30,000, whereas low governance, you're down around 1,000 or less. And we know that in our focus on improving public health, this continues to be one of the still under-focused, underfunded areas of our work. What to do? As Steve said, in complete agreement, reduce militarization and the unregulated sale of arms, particularly in unstable contexts, reduce violent conflict and promote nonviolent negotiation processes. How can we contribute to nonviolent resolution of conflicts, not the violent ones? We know this only creates cycles of more violence. Control corruption, strengthen the rule of law, and support democratization, but not a singular form of democratization. And that's why the term democratization is used. It's not just democracy. There are multiple ways that we can think about democracy as long as we keep the principles of transparency, participation, accountability, equality as the foundation of those. Each society and our global community has to come up with the institutions of democracies that fit those contexts. There's no singular model. And strengthen civil society organizations, particularly at the grassroots, in the ground, that contribute to human security and sustainability. We can also promote the human right to health and integrated programs to solve public health challenges. Recognize complex patterns. Armed violence breeds social and environmental damage, which then in turn result in poor public health. And address the range of public health challenges, especially long-term and mental health effects. So, where do we go in terms of the United States? Steve began to talk about the various policies that we have, and some, in fact, are actually quite wonderful in their intellectual design, in their policy structure. It's oftentimes in the way they are implemented that we fail. So the Global Fund, funded in 2002 by wealthy nations, directed by the UN to fight AIDS, tuberculosis, and malaria. The Global Fund aims to be the manager of funding partnerships between government, civil society, private sector, and communities to finance health approaches that are not influenced by a particular politics of one donor. The US is the single largest donor, but is contingent upon others' donations and is limited to 33% of the fund, as you see the figures in 2004, 5, and 6. The Global Fund claims to be a hands-off financer that relies on local partnerships for program implementation in 93 countries and requires that programs build or coordinate with existing efforts. As you can see, many of these elements are ones we would believe in and believe are the right ways to go. The Millennium Challenge account, created by President Bush and run by a new government corporation, the MCA is devoted to projects and nations that govern justly, invest in their people, and encourage economic freedom. It aims to fight poverty through government and community structures. It's awarded to countries that demonstrate good governance, those things that we believe are the critical fundamental factors for any long-term achievements in public health. Where the Millennium Challenge account will go is still an open question, but there is possibilities there. Usaid development and partnerships. One of the least known, but perhaps most exciting part of USAID's work is the Global Development Alliance, and its effort to combine ideas and resources across sectors. And so let me take a moment here and talk about partnerships. We know in this complex, asymmetrically globalized world that no single sector, government, the private sector, civil society, academia, can make a difference by itself. We all have a role to play, ordinary citizens included. The new way that we know we have to work together is in partnership. How can we take the best that each of us from our different host sectors and institutions and organizations and work together, rather than do so much of the duplication and redundancy and cross purposes that Steve mentioned in his talk. And so there's a lot of movement in this area towards partnership. And the US corporate sector is moving slowly, much too slowly from my view, but is moving in. And there are leaders in the US corporate sector. And this is where we need to move even further in the future. Again, democracy and good governance programs were found to be instrument in global growth of democracy and also improvements in public health, education, and welfare. USA global health programs have seen increased funding over the last few years, particularly PEPFAR, but as Steve mentioned, given the larger structural situation, PEPFAR is still, again, only the beginning of what we really need to do. And I want to talk increasingly also about the new foundations, and of course, the Gates Foundation here. We know what they are doing. We know what a great difference they can make in our world, and we are proud to be partners with them. but I think even our colleagues at Gates would agree that they themselves, as part of our global community, are just beginning to figure out what we need to do to make a difference in the world. The Open Society Institute, and I want to not underestimate individual and grassroots direct giving, because oftentimes, as we've learned from microfinance around the world, it's not necessarily the $5 million, $10 million grants that make the difference. It's the small contributions in the right places, working in partnership, focused on local capacity building. So, US policy more broadly, not just the US government policy, but US society, towards realizing global health, good governance and anti-corruption efforts, strengthening civil society, particularly in the home countries, partnerships and integrated programs for fighting poverty, accesses to resource and education, not only an inclusion, but a prioritization of women and young girls, community-based aid programs, and attention to the most vulnerable populations. In our view, at the Lindenberg Center, and I think with our colleagues across campus and around the world, we think of a golden enabling environment for public health success. New technologies and innovations are critical, without question. But as Steve has rightly noted, and other speakers in this series, without the organizational and human capacity and the support for that organizational and human capacity, no matter how many inventions we have, they won't be successful. And underlying both of those, in our view, is advocacy for good governance. Without good governance, you can't have long-term solutions for organizational human capacity, and those inventions are not going to do the job that we want them to do. In this regard, if I can end with this hopefully positive and contributing program of ours at the Lindenberg Center, we have begun a transnational action learning project. Now, what is this project about? It's to develop conceptual frameworks for public health policy and advocacy in sub-Saharan Africa and South Asia, to do our part to contribute to good governance. It assembles an unprecedented database on public health organizations and their networks across sectors for advocacy and policy. There is a vibrant civil society in most countries around the world, and particularly in sub-Saharan Africa and South Asia, where many of the great global health challenges do exist. But oftentimes, the data and the information that allows them to connect with one another doesn't exist. This database that will be very user-friendly and accessible to all is part of our contribution to helping to form, support, strengthen those organizations and networks. And is part of the larger vision that President Emmert, Provost Wise, Vice Provost Jeffords are leading us to be global citizens. I have great belief that the University of Washington can do this, can be part of a renewed democratic United States at the level of the government, at our various levels of government and in society, and that we can make a difference in this world. Thank you very much.